Hi, my name is Jeff Lancet. I'm at the Moffitt Cancer Center in Tampa, Florida. And today I'll be reviewing with you the results from our ASCO presentation about the five-year final results of a phase 3 study of CPX-351 versus 7+3 in older adults with newly diagnosed high-risk or secondary AML. And for those who may not be familiar, CPX-351 is a liposomally encapsulated formulation of cytarabine and daunorubicin in a fixed 5:1 synergistic molar ratio. And it's this particular formulation and this ratio that is felt to induce better drug delivery and more prolonged drug exposure, hence the potential advantage over conventional chemotherapy. So a number of years ago, we had launched a phase 3 trial comparing CPX-351 against 7+3 in older adults with secondary AML or high-risk AML, mainly patients with AML from prior MDS. And in this original phase 3 trial that was published now a couple of years ago, we demonstrated that there was a significant survival advantage amongst patients treated with CPX-351 compared to those who had received 7+3. And at the time of the original publication and analysis, the median follow-up was approximately 20 months. So this particular analysis presented at the ASCO meeting this year was an update at the 5-year time point of this phase 3 clinical trial, really to determine whether the data were holding up over a more prolonged period of time. So that was the purpose of this particular analysis. So to really cut to the chase, in this analysis, we had looked at a median follow-up time of about 5 years and looked at the same outcomes that were assessed during the original analysis, namely overall survival and survival post-transplant. So in terms of the overall survival at 5 years, the data held up very well and were very consistent with the 3-year data. So a significantly longer survival after 5 years of follow-up amongst the CPX-351 treated patients compared to the 7+3 treated patients. The difference was about 3.5 months in favor of the CPX-351. And in addition, there was a hazard ratio for death that was lower amongst the CPX-351 treated patients by about 30% over the entire course of the study. The second important analysis that was performed was the landmark analysis amongst patients who went to allogeneic transplant. And as you may recall, in the original cohort of patients, about 35% of the CPX treated patients and about 25% of the 7+3 treated patients went on to receive allogeneic transplant as part of their leukemia care. So when we did a landmark analysis of those patients from the time of transplant, we observed that there was a significantly longer survival after transplant amongst patients who had received CPX-351 compared to those that had received 7+3. So those data were true at 3 years, and they were also true at 5 years, with very little difference in overall survival amongst the patients who were landmarked at the time of transplant. And then finally, we analyzed the outcomes amongst patients who had achieved a complete remission or a complete remission with incomplete count recovery to determine the effect of CPX versus 7+3 in those patients who achieved remission. And similar to what we had seen at 3 years, at the 5-year time point, the patients who had achieved CR or CRI with CPX-351 had significantly longer survival than patients who had achieved complete remission with 7+3. In addition, amongst the patients who went to transplant, who had received a remission from either CPX or 7+3, the transplanted patients in remission also lived longer if they were assigned originally to the CPX-351 arm compared to the 7+3 arm, and that data was also holding up very strongly at 5 years. So in summary, the results of this analysis confirmed really the long-term efficacy of CPX-351 as primary therapy for older adults with high risk or secondary AML as a preferred therapy over conventional 7+3 chemotherapy. And certainly it's reassuring to see that the long-term data support the findings that were observed earlier. And I think lends confidence to the fact that the CPX-351 drug can be considered a standard of care and should be considered a standard of care for more fit patients with secondary or high-risk AML moving forward. Thank you very much.